afternoon in Africa. Good morning in the US. To everybody that's online on this wonderful day where we have this wonderful webinar. My name is Marietjie de Villiers. I'm a family physician and a health professions educator from Stellenbosch University, South Africa in Cape Town. And I'm the current AFREhealth president, and I will be chairing this webinar. I want to say welcome to each and every one that is registered, that's online and that's still coming. We have a wide variety of people, many countries. We've actually, because we've decided to do the registration, we can see what countries people come from. And we can send that information to Roger or somebody if they need that. Also, it's a very nice interprofessional group of people that's joining this afternoon, from very senior professors to students also. So we're very happy about that. So just to say that we will be recording the webinar and we will put it up on the website, the AFREhealth website as usual. And let me just introduce the team this afternoon very quickly. We have Professor Fatima Suleman from Durban, South Africa. She's going to, hello, cold in Durban. She's going to moderate the questions for us, and she's very good with that. So she will thematically organize the questions and make sure that each speaker gets questions. We organized this webinar to have a good 20 minutes for questions and discussions. And we hope it will all work out like that. So I mustn't talk too much in the first place. Then we have 3 speakers, and they will go in the following order. And they will introduce themselves. I will just mention their names. They can maybe just give people a wave now. Professor Ian Couper from Stellenbosch University.
Hello.
Thanks, Ian. And then we will have Professor Elsie Kiguli-Malwadde from Uganda, Kampala. Elsie, can we see your face? Okay, she'll give us a wave later. And then
no, she did give us a wave. She's just muted.
Oh, she did. Oh, okay. Yeah, I can't see all the faces. You're right. And then we will have Professor Hoffie Conradie. He's a retired professor from Stellenbosch, but he's working almost full-time on the strike project at the moment. Okay, so I think just to say, I want to say a special welcome to Dr. Flora Kurtz and Dr. Roger Glass from the NIH, who is part funding AFREhealth. We are so happy that you've made time to join us today. It's very nice to see you because we don't get time. We don't get an opportunity to see you now in this time of the pandemic. And then, of course, I saw that Dr. Marietjie Razak from HRSA also registered. I'm not sure if he's on yet. Welcome to him. And then, of course, from UCSF, we have Dr. Eric Goosby. Thank you so much that you joined us. Mike Reed and Cheyenne Martin also registered from UCSF. So they will probably still come on, and they are our great partners in the strike project, from which you will hear a lot today. Yeah, I think that's, and then of course everybody. Clara, are there more people in the waiting room? They're coming in slowly.
No, Marietjie, the waiting room is disabled.
Is what?
The waiting room is disabled, so there are no people in the waiting room.
Oh, okay, yeah. Okay. Hi, I see Joe Carlos are also here. Okay, so I think we were going to start with Professor Ian Couper. Ian, can you share your slides and then introduce yourself and fire away? People, just remember to mute yourselves. So if you don't get background music, you're welcome to show your face. But if your internet connectivity is low, then perhaps not. Okay, Ian?
Can you see my side, Marietjie?
No, I only see you.
Okay, let me try that again.
Now it says you started screen sharing.
There we go.
Yes, yes, I can see that.
That should be right. Good afternoon, everybody. It's good to be with you, even though it's virtually. As you will have seen, I'm speaking about the myth of interprofessional education. That's who I am, and to say that this is a particular interest of ours in the Ukwanda Centre for Rural Health, that interprofessional collaboration is one of our strengths that we have. And so this is a topic that is very important to us and to what I do. So why do I say that IPE is a myth? Now, what is a myth? If you look at the dictionary, a myth is a traditional story, especially one that explains a natural or social phenomenon and typically involves supernatural beings or events. So how does that relate to interprofessional education? It's also, another definition is that it's a widely held but false belief or idea. So maybe you think this is heresy, that I'm saying interprofessional education is such a myth, such a false belief or idea. Heresy being something that goes against what is generally accepted. So let's define IPE first. WHO defines it as occurring when students from two or more professions learn about, from, and with. Remember those about, from, and with each other to enable effective collaboration and improve health outcomes. Another set of authors define interprofessional education as a collaborative approach to develop healthcare students as future interprofessional team members. And that to me is the key as to why I'm saying this is a myth. So what is the myth? Well, we said it's a traditional story explaining a natural social phenomenon. What seems to me to be the explanation for IPE is that we have A, B, and C, the different health professions. They train in their silos, and then A, B, and C work in their silos. That's the situation. Therefore, let us train A, B, and C together, then they will work together. I think that's a widely held but false belief or idea. There's no evidence that training people together is going to get them to work together. If you look at the literature and try and find the evidence for that, I challenge you to see what you can come up with. I think you'll come up with nothing to prove that simply training people together is actually going to get them to work together. What is the reason for that? There are many reasons. I want to share three that I think are behind it. Firstly, we don't have well-functioning interprofessional teams in practice. Where are the role models? I think the role models are these supernatural beings in the myth. They don't actually exist by and large in practice, and that's the problem. Especially because by and large we train in complex big hospitals where interprofessional teams are very difficult to function. Examples I have seen of them tend to be in smaller, more rural facilities, etc., where there's a much more closer relationship. So firstly, we don't have these examples. Secondly, we use a theoretical model of interprofessional education. We teach IPE in the classroom without using real-life examples. Yes, we might have paper cases, but because people don't see it, they haven't felt it, and they're just discussing it on paper, it is fairly theoretical for them, and they don't understand it. And I would, by the way, not classify what I call parallel learning as IPE. So what some institutions do, and I'm afraid my institution, Stellenbosch, has done this as well, it puts a whole lot of professions together in a classroom, gives them a lecture on whatever topic it is, and expects somehow there to be osmosis between the professions just because they're sitting in the same classroom bench together without ever interacting. The WHO definition, if you remember, is about with and for and interacting with each other. For me, a critical issue is that we do not address issues of power. Power relations are critical in interprofessional teams. And if we don't address the issue of power, we don't address the fact that the healthcare system is incredibly hierarchical. We're like ostriches, we're just burying our head in the sand. And until we actually look at the issue of power and hierarchy and deal with that in our discussions, we're missing the key issue that prevents these teams from actually working together. But that's a subject for a separate discussion. I couldn't do another hour-long presentation on that issue. So how do we address this? For me, we've got to think and do interprofessional collaboration. We've got to move past the notion of just interprofessional education and say, how do we collaborate together? How do we collaborate in training and collaborate in practice? So what is that collaboration? There's an excellent article from the world of social work that talks about interdisciplinary. We can read that as interprofessional collaboration. They describe it as an effective interpersonal process that facilitates the achievement of goals that cannot be reached when individual professionals act on their own. We can actually get students to the point of realizing that as long as they work on their own, they will not achieve certain goals. But when they work together with their colleagues from different areas, whether it's students or graduates or practicing people, when they realize that, then we're getting collaboration starting to happen. There's increasing literature on this around the benefits of interprofessional collaboration, that it can reduce staff absenteeism, it can help to educate health professionals, enhances work environment, patient safety, improves quality of care, etc. And if you look at the literature, there are a number of factors that are needed for effective interprofessional collaboration. There has to be a commitment, and there has to be shared trust, regular discussion. A lot of those issues are only achieved when we get to addressing issues of power and hierarchy and how we relate to each other and how we challenge each other and how we ask questions of each other, etc. Clear shared objectives with that common vision that is going together. It helps if people are together over a long period of time, that you have a low turnover of personnel. So all of those things are critical in achieving interprofessional collaboration. So I want to come back to the WHO definition of interprofessional education that I mentioned earlier. It occurs when students from two or more professions learn about, from, and with. Remember the about, from, and with. But why? To enable effective collaboration. So they actually speak about that. And if we build that into it, then interprofessional education maybe is not a myth any longer. And so I think that definition is very useful and very important. So in Ukwanda, we speak about interprofessional education and collaborative practice, or often just interprofessional collaboration, because we see that as so critical. How does this relate to STRIPE and what we've been doing in the STRIPE project? In the workshops that we've been running, we make sure we involve professionals from a wide range, but they're professionals from existing teams in the different sites that we've been running this at as part of the SunStripe project. We have real life case examples, things that come from reality. They're not just ideas developed on paper. But critically, in the workshops that we've been running, we ensure that the small group discussions are mixed groups, of people from different levels, students, graduates, but also from different professions. And we worked actively to break down hierarchy. We do things like calling first name, making sure everyone knows that their voices are equally heard, that everyone takes a turn to comment, to report back, etc. Those kind of strategies to make sure that we are addressing that. So I'm not saying that's perfect, but it's some ways that we can move towards making sure that IPE is a reality and can lead to collaboration. So I think we can destroy the myth of interprofessional education if we make it real, if we make it real in the context of interprofessional collaboration. Thank you. Let me stop sharing.
Thank you, Ian. I like that. Really good, controversial, always challenges our beliefs and attitudes. Hashtag make it real. Thank you very much, Ian. So I'm going to ask Elsie Kiguli-Malwadde now. Thank you, Elsie. We can see your slides. You can carry on.
Thank you, Marietjie. Can you hear me?
Yes, you're welcome.
Oh, great.
Yeah,
I'll just show my face probably.
Yes, please. That we can see you for real. Oh,
yeah.
Yes, we can see you.
That,
yeah,
I'm not a robot, thank you. But I'll put it off because of bandwidth and continue with my presentation. Okay, thank you. Welcome everyone, and thank you so much for coming for this webinar. I'm Elsie Kiguli-Malwadde, as Marietjie said. I'm the Secretary for AFREhealth, and I work for an organization in Uganda called ACHEST. There are many people that I would like to recognize, so I've just put the logos on that slide because this is a work that we do in collaboration, AFREhealth, with many other organizations. And I'm going to talk about rolling out the COVID-19 online course from face-to-face to virtual mode. So we are really in virtual mode because of the challenge of COVID. So just a bit of background. You've heard Ian talk about the Stripe HIV project, which AFREhealth has been running with the University of California, San Francisco, and is funded by HASA. And in full is strengthening interprofessional education for HIV. And AFREhealth with UCSF came up with 17 modules on HIV. And these have been taught and shared at 20 institutions in 14 countries, as you can see on that map. And as we are going on with the implementation of this project, came the challenge of COVID-19. However, we had to stop the face-to-face interactions, but we took this as an opportunity, and together with the UCSF, we came up with the COVID-19 module in addition to the other modules that we had. So I've talked about the problem. So COVID-19 comes in and we have social distancing, no face-to-face interactions, and schools also closed. And at the same time, this is a novel disease. There was variability in information, knowledge, and even in quality of care, and this continues. And most of the health workforce had never handled any of these cases. So there was also the lack of support for them in clinical practice. And of course, it persists the suboptimal interprofessional training opportunities, as Ian elaborated. But looking at this, AFREhealth with partners found a potential solution to continue this virtually with online training, and also make sure that we expand and enhance this interprofessional education. As I said earlier, we developed a COVID-19 module, and this was really with a focus on training frontline health workers, because they really needed training on this. But just to go back a little, why interprofessional education for Stripe HIV and COVID-19? It is AFREhealth's mission to be interprofessional. And it's really great to see, even at this webinar, that this has been depicted. All professions are actually represented here. So AFREhealth would like to build inclusive communities of practice within Africa and globally. So that's why we really emphasize interprofessional education. And we want to sustain the gains of MEPI and NEPI, because we started separately, but we have combined as a team, and now we've brought on board many other professionals to work with us. And we also believe that complex health problems can only be solved by all health professions working together as a team. And this helps to overcome traditional barriers. So that's our belief in AFREhealth. So looking at that, still with the help of UCSF, we conducted a very small survey to look at e-learning within AFREhealth. About 17 schools participated. It was short and the call was very short. We found out that 4 out of those 17 schools that responded had Zoom licenses, and 3 of them have learning management information systems. And we also asked them, how are they managing now with the COVID-19? The 7 of them are using online platforms like Zoom, Meeting, Microsoft, and Google Teams. Some even have resorted to WhatsApp, and others are using Skype. So they are using a variety of online resources. And those that are involved in the Stripe project, we asked them what their plans for the next 3 months were. And some of them said they are going to translate the modules into other languages. All these modules are currently in English. Some are looking forward to reopening face-to-face because their schools had closed. But many of them want to train faculty and students on online facilities. And we also asked them about their limitations. And they said many of them, their faculty are really busy with the pandemic. They are hardly doing anything else. And as I said, many schools have completely closed. So the students are at home and also the faculty are at home. And some of them find that the online training has very high costs. But also there's the lack of IT and technical support at most of the schools. There's also the lack of internet, though right now in Africa, there's been an increase in availability of internet and better bandwidth, but it's still a challenge in many areas. And even where the internet is available, it is unstable. And there's also a lack of hardware. Most of the students, when they go home, they may not have laptops, they may not have desktops. Some of them don't even have smartphones. But also there's the limitation of knowledge on e-learning, both for faculty and students. And I must also put a disclaimer here that I'm not an expert in e-learning, but learning slowly by slowly. And so we said, what is needed? We have the participants, we have students, we have frontline health workers, people who are eager to take part in interprofessional education. And also we have facilitators that are eager to facilitate interprofessional education. There's limitation with internet and having data, but there's something at least is better than it used to be. And even the provision of hardware is now better. And for COVID-19, we have that COVID-19 module. So the content is there. And we said, okay, the will is there for AFREhealth to roll out this module. So how are we doing it? We already started with the webinars on COVID-19. Jean Nashega has been good, very good to lead this, and they've been really well attended and successful. And so with the help of UCSF and funding from HASA, PEPFAR, we are planning to transition to online training in the next 3 months. In fact, this has already been started by Stellenbosch and Makerere University, and Hoffie will share a bit of that later. So 4 schools have been selected to continue with this. University of KwaZulu-Natal, Makerere University, Stellenbosch, and Nkrumah University of Science and Technology. So they will continue with this, with the online training. And then there's also plan to create a learning management information system for AFREhealth. This is in early stages, but it's in plan. And so with that in mind, we would like to ask representatives of schools that are here and have a learning management information system at your university or college, would request that you register in the chat box so that we know who you are and where you are. And with all this, we are thinking that AFREhealth, in partnership with others, we can innovate and continue online learning with, of course, the facilities that we have like Zoom, Go Meetings, and many others that we have mentioned before. But what are the key considerations, things that AFREhealth would like to keep in mind? The interprofessional interaction, that one we would like to make sure that it continues. But we are also aware that there's digital inequity. So we want to see how to overcome this and see that all types of learners can benefit. If we can do online and synchronous, well and good, but can we also do asynchronous? Can we use smartphones so that we can reach more learners? And we would also like to maintain reaching undergraduates, because we know that these will be the frontline health workers. But at the same time, we shall keep in mind the HACCP's interest in current frontline providers as they give us the funding. We also need to consider how health systems are changing and advancing as a result of COVID. We realize that so many things have changed as COVID-19 is with us now. So we would like to create solutions that not only benefit education, although that could be our focus right now, but also keep up with health system changes, looking at things like telemedicine, mHealth, and many others that are being developed in health systems. So I love this African proverb. If you want to go fast, go alone. If you want to go far, go together. So we are really grateful to all our partners who are coming with us so that we can go far. AFREhealth knows that it can't do it alone. And one time I presented this and Marietjie, our president, added on, leaving no one behind. So we would like as AFREhealth to leave no one behind, to work together to continue to roll out not only Stripe HIV online training, but also include the COVID-19 module that has been developed. Thank you very much. Over to you, Marietjie.
Thank you, Elsie. That was great. Yeah, actually, going together speaks to interprofessionalism, and leaving no one behind speaks to social justice, doesn't it? Hoffie, okay, you will introduce yourself on presentation screen. There we go. Okay, that's right.
So I'm Hoffie Conradie. I'm a family physician and emeritus professor of family medicine and primary care at Stellenbosch University, and a facilitator for Sunstripe HIV and the face-to-face workshops. Now, what I love doing most is being in clinical work with students, be it postgraduate or undergraduate students, and love doing the face-to-face workshops on HIV with interprofessional groups. And now we cannot do that anymore. So the challenge was to convert those workshops into online training. And I would just like to give you a feel for how we do the Sunstripe COVID-19 workshop online. As Elsie has mentioned, the COVID-19 Stripe module was developed by UCSF and Michael Reed and Jayan, and it was developed as a face-to-face interprofessional education workshop of 90 minutes, usually with 30 to 40 participants and 3 to 4 facilitators. Normally in these workshops, we have a facilitator guide printed for facilitators, a facilitator PowerPoint presentation with answer slides, and then a learner guide that we print for learners. There's then a patient scenario, and then different activities around that patient scenario discussed in small groups that then report back to the big group. So now we had to adapt that for an online workshop. Normally we have 25 to 30 or sometimes more participants from different health professions. This could be students or qualified professionals, sometimes a mix. And the way we present it at the moment is 2 90-minute online sessions either on consecutive days or with a day apart in 1 week. So there is a main presenter in the main room like we have now that has a PowerPoint presentation for the whole group. We then break up into smaller discussion groups, and there's a facilitator PowerPoint presentation that's shared in those breakouts. As I said, there's a main presenter, a facilitator for each breakout room, usually 4 to 6 facilitators. And then in the breakout room, we have 4 to 6 participants. And the participants are representative of the different health professions in that small group. We use Zoom meeting, like you did today. We use pre-registration. We ask participants before the workshop to do the PACT Global COVID-19 interactive online modules. So there's a PACT Global Clinical Management module. It's about 2 hours, and a PACT Global COVID-19 PPE, health worker exposure and occupational stress module. So we find this quite important for participants and helpful for participants to do this preparation before the workshop. So the Zoom tools that we used, I mentioned the breakout rooms. Unfortunately, we can't give you a feel for that. We don't have the facility on this Zoom meeting. We also use polls where we put up a questionnaire on the screen, and participants then fill in that questionnaire, and then we share the results and discuss it. And that, unfortunately, we cannot do that either today. And then there's a chat room that you're familiar with, where people can make comments and ask questions or make contributions. So this is what the breakout rooms look like. So before the workshops, we divide the participants into 5 or 6 or 7 breakout rooms. And as I said, we make sure that those rooms represent all the different professions. When we go to a breakout room, we specify a time that is being controlled by the host of the meeting. So you join that breakout room, and then when time is up, you are automatically returned to the main room. So we use a patient scenario. So I made a bit of a shortened presentation here of a scenario. So it's Mrs. Zulu, a 61-year-old. She lives in Khayelitsha and works as a childminder for a couple with a 5-year-old son. She developed symptoms of fever, cough, and sore throat and presented at a local clinic. She's aware that there are cases of COVID-19 in her local community. She is hypertensive, obese, but HIV negative. We give here the vital signs, and we state that she's not short of breath. So this would form the basis for our discussions in the different activities. And I'll just like to give you a feel for some of those activities. So the first activity, we ask the small group discussions to discuss the relevance and the importance of the incubation period. And we also ask them to think about other conditions that can present with this. So we also ask them to look at the typical clinical presentation of the infection, the typical symptoms and signs. So when the participants in the small groups come back, we also usually ask 1 or 2 of those small groups to report back to the main group. And once they report it, we'll put up a slide to summarize the answers to that questions in the small group. So this is a slide setting out or explaining the incubation period. So the next question in the small group would be that Mrs. Zulu is the concern is about her COVID-19. So we want to ask, what are the key screening questions you might ask, and what other conditions should you consider when a patient presents with these symptoms? They will go back to their small group, usually about between 5 and 10 minutes, and then come and report back. This is just a slide from the pre-reading material where an algorithm of how a patient will be managed when they present to a health facility with symptoms suggestive of COVID, and the triage then, if the symptoms are suggestive, then they become a person under investigation. They will be given a surgical mask. If they complain of shortness of breath, then they would immediately go to an emergency area for COVID patients. If not, they will go to a special area where COVID suspects will be further evaluated and seen and assessed. Then we also look at the importance of infection prevention control among health workers. And here is where we give some information around precautions, standard precautions, transmission-based precautions, contact precautions, droplet precautions, and airborne precautions. And then we ask them to fill in a questionnaire with 4 questions, and they have to mark the answer that is incorrect. And once they've done this poll, it takes about 3-4 minutes. Then we can share the results in the main group, and we can then discuss the results. I wish I could have just shown you one of those and ask you to participate in one of those polls. We also have another small group breakout where we ask each group to discuss this table here. We ask them to look at different scenarios, provider role and patient contact. We look at a doctor who's examining a suspected COVID patient, a nurse doing a respiratory tract sample, a physiotherapist who is consulting a patient not suspected of COVID, a pharmacist, a community health worker, a hospital administrator, and a patient. And we adapt these scenarios depending on who is attending our seminar, our workshop. And then we ask in each situation that the participants then fill in here. What would a doctor, what PPE is appropriate for a doctor to wear when he's examining a suspected COVID patient? And they then report back to us in the main group, and we discuss that. We also look at a risk assessment for healthcare workers. What is their risk of becoming infected? And there are 2 concepts that's important. One is, what kind of contact did the healthcare worker have? And we define close contact as less than 1 meter with a PUI or COVID patient, direct physical contact, direct contact with secretions, performing an aerosol generating procedure. So that would be a close contact. We talk about a casual contact when the healthcare worker has been in a room or ward with a PUI or a COVID patient, or had been face to face with a PUI or a COVID patient at more than 1 meter distance. We then discuss the concept of risk, of minimal risk, of sorry, my thing is just obscuring it here, of low risk, of moderate risk, and high risk in different scenarios where the exposed healthcare worker wears the appropriate PPE. They're at minimal risk if they did not wear the appropriate PPE, but was a casual contact, they're at low risk. If it was a close contact with a PUI, they are moderate risk. If close contact confirmed, they're at high risk. And then we discuss what would be the management of that. And that's where we put up a poll again and test the knowledge of the participants and then share the answers with them. We also then look at the clinical management of the patient, Mrs. Zulu, who meets the criteria for COVID-19 testing. And we have 3 scenarios here. And we divide those scenarios up in the different small groups, the breakout rooms, and we ask them to discuss what they would do and then come and report back. So the first scenario, the patient is sick enough to be admitted. Second scenario, the patient can go home, can be tested, but the test is not available. And the third scenario is where the patient can go home, but there's no facility for COVID testing. And we want them to discuss those different scenarios. Further activity is when Mrs. Zulu is discharged, what are the key recommendations that we will give to her and to her caregiver? Here we actually ask the participants in the small groups, we divide them again in the small groups, to choose a healthcare worker and a patient, and to actually do a role play online with the other participants in the breakout watching to see how that interaction plays out between the healthcare worker and the patient. The further activity is then around containment and mitigation. A further activity, we'll put up the slide as after the discussion. A further activity would be around interprofessional teamwork and how the professions can support each other, and that's a very important discussion for us as we are really want to promote the interdisciplinary teamwork. And then we have a final discussion on how do health workers cope with stress and anxiety during the epidemic. Just want to give some indication of what we've done so far. During April and May, we had two separate workshops, one for the STRAP collaboration institutions, and we had 63 participants there, and then we sent out an invitation to AFREhealth associated institutions, and we had 61 participants there. And then at Stellenbosch University itself, we had 6 more further workshops with a total of 128 participants. And this just gives you a feel for, in those workshops, we had a mix of different professionals, and it was mainly medical students, and then occupational therapy, physiotherapy, dietetics, and speech and language therapies. Students or professionals in a mix, usually. The final, just to say that the overall feedback, if I can try and summarize that, was that the participants felt that the preparation they've done for the workshop was very important, but during the workshop, it was really nice to have a very interactive discussion between different professionals. Thank you, Marietjie.
Thank you, Hoffie. Okay, so without further ado, I'm going to pass over to Fatima to manage the questions for us, please.
Sure. So one of the things that was very early put on, and I know there was some answer to it, but I was wondering whether the speakers wanted to add more about it, about interprofessional education in a clinical setting in terms of COVID-19. So as the current pandemic is continuing, with the constraints with regards to students being able to come back to universities and then students being able to access clinical settings, what are the kind of ideas emerging in relation to IPE?
So Fatima, if I can answer. I mean,
Sure, Ian, go ahead. Yeah,
some of that has been covered in what I think Elsie and Hoffie were talking about. But an example of what we've been doing in Ukwanda with our collaborative practice sessions is that we just introduced them. We're doing virtual home visits, a team where they get interact with people in their home on through direct voice call or WhatsApp or whatever. And the next step we're trying to move to, we just getting sorted out, is for a community health worker to go into the home and for the students to actually be interacting with the people in that home through the community health worker. I mean, that's apart from the actual in the hospital and the health center's clinical interaction that's happening. But at the moment, in our context, only the medical students have been allowed back by the government. So we actually not have been the rest of the students. They will be coming in the next couple of weeks, but they can join the online sessions.
Do any of the other speakers want to add anything to that response? Then I think it leads on to the next question quite nicely, which is also sort of to all the speakers. And it's, has there been any change in practice within the healthcare settings where we've been running these workshops to a more interprofessional collaborative approach, since you do small work and address hierarchy challenges? And how does one assess this potential change in practice behavior? So maybe I'll go with Elsie and Hoffie. Can you both think about whether there's been any change in practices, and how are you assessing these change in practices?
Well, what I would say, project in Makerere, and although Makerere has been doing some interprofessional education before this, but then with the involvement of frontline health workers, I was happy to note, of course, this is a personal perception and experience. I was, right from the word go, we dropped the titles in the training and the collaboration. So I was very happy to see that people were really interacting in these workshops without the titles, because this is very common in the clinical setting. We usually have titles of professor, doctor, and what have you. But in these trainings for Stripe HIV, I was glad to see that all those were dropped. As for the evaluation for Makerere, with which I'm most involved, we are planning to do an evaluation later on, but we have not really evaluated what has changed in the clinical setting. I don't know if Hoffie, maybe you've done some evaluation yet.
Yeah, it's Hoffie here. I think we're not yet sure about the impact of that in the clinical situation. What the situation is that many of the practitioners, especially the allied practitioners, are not back to full clinical work, and the students except the final years, are not back on the platform. So that's certainly, I think, really important that we evaluate in future how this impacts on the collaboration on the clinical platform.
Thanks, Hoffie. The next question is also to you. So it's about, are there any positive aspects of online learning that you plan to continue post-COVID-19? Example, making it easier for remote learners and faculty to join, or for easy polling and those sorts of things.
Yeah, I think it's definitely going to change how we do, because the workshops that we've been running, the Stripe HIV workshops have been at distance places, which involves quite a lot of traveling for us, and also for the local people often. And it was also quite an expense to have the and logistically difficult to have the facilitator guides, and especially the learner guides, printed and distributed. I think the possibility of running these workshops online makes it possible for many people to do it from their workplace or even from home, and still have in small groups that interprofessional contact and discussion and with other professions. So I think it will definitely change the way in which we do it in future. And there's the possibility, like Elsie mentioned, that we will do the other HIV modules also develop them to be done online, and also think of other possible conditions that we can discuss, especially a disease like diabetes or where there's multiple comorbidities.
I'm going to sneak a last question in as a prerogative of this moderating the questions. And it's basically about the fact that I want to link it to what Ian has been saying right at the beginning about IPE being a myth and how it should be with clinical practice. We've been doing STRIPE training at the undergraduate level, trying to link in all the students at that point, because we're trying to see that that will translate into interprofessional collaboration in practice. Is there a danger that we try to do that, but they go into a setting where there's still this kind of vertical separation between the professions? So like the medical practitioners will go on their ward rounds separately from maybe the pharmacists, and maybe the nurses are taking care and chatting to both the pharmacists and the doctors separately and not at the same time. So, you know, what's the future of IPE in a clinical setting in Africa?
Maybe I could say something about that. I see that Ian would also like to say something. I think the future looks bright considering where we've come from. And when we work with the frontline health workers, as Ian intimated, is that when the groups are smaller, it seems to be easier, but in the large institutions, the tertiary hospitals, it seems more difficult. And we hope that change will come. Change takes time, but we can't give up, because we know that this is something that is important. And for AFREhealth, we would like to ensure that we keep this on our radar, because our organization is really interprofessional and we wouldn't like to leave anyone behind.
Thanks, Elsie. Ian?
Yeah, there's an article I really want to recommend by Hadara and Lingard entitled "Are We All on the Same Page? A Discourse Analysis of Interprofessional Collaboration," which they published in Academic Medicine. And essentially it was a review of the literature around interprofessional collaboration. And they said there are two motivations behind, essentially, if you read the literature, why we do that. It's either because we believe it's going to improve patient care, or we believe because it's going to emancipate our relationships. In other words, it's going to deal with hierarchy. And I think unless we are looking at both, we're not going to achieve it, because people will go into a system where, exactly as you're describing, they'll go into a system where people who say things that, they say out of not having status are challenged. I mean, one of the first, my first experience of this, doing some research on this many years ago, was nurses telling me that when they ask doctors questions about what they're doing, the doctor turns around and says, "I didn't see you at medical school." You know, as long as we have that kind of interaction happening, we're not going to make a difference. So we have to be addressing those relationships and understanding the issue. We've got to emancipate ourselves if we're going to make a difference.
Thanks, Ian. I think that's a great answer. And thanks to Mike for putting up the link to the article. I'll make sure that we put that up on the AFREhealth website as well. I have 1 minute where I can give all of you final words as speakers before I hand over to Marietjie. So is there anything else you want to add to the discussions or the questions that were posed to you all today? If not, thank you all for your participation, and I'll hand over to Marietjie to do the closing.
Thank you, Fatima. Very efficient as always. Before I close, just one comment as a facilitator for the small groups is that the feedback that we get is that, yes, the pre-reading the pack is very good. And you see that those who actually read it, they feel more confident to discuss. But they feel that in the online groups, the discussion amongst themselves with the facilitator it sort of empowers them, but it also helps them, especially with COVID, to come out with their fears and concerns and anxieties and unsurities, especially in the end when we talk about, you know, what do I want to be in this pandemic, the 3 stages. So there is more than just a knowledge transmission. There's also a behavior and an attitude transmission. My ideal would be is that we could add skills to these workshops, that we can donning and doffing of PPE in these workshops, but all of that, you know, take time also. So that we have all 3, you know, the knowledge to, as well as the psychomotor and the affective domains in these workshops. So I want to first of all thank Fatima, who managed the questions for us, then our 3 speakers, Ian, Elsie and Hoffie. Thank you. You kept very well to your time. Thank you very much. And then I want to thank each and everyone who attended. We really appreciate you. And then the Secretariat, Clara, who manages the Zoom platform, and Iranius, who helped us, who set it up. So thank you very much. We will put up the recording on the website. If you have any more questions, you're welcome to post it there, and we will ask the speakers to respond back to you. Thank you very much. Have a lovely day.
Thank you. Bye-bye, everyone.
Thank you. Bye-bye.
Bye. Thank you, Marietjie.
Thank you.
Bye.
Bye-bye. Thanks.
Yeah, thank you. Bye.
Thank you.
Thanks, Dr. Razak. Good to hear you.